Welcome everybody to this month's Scientific Roundtable. I want to begin by thanking Dr. Kline for spending some time with us to talk a little bit about his studies using AI applications in radiological imaging. Dr. Kline is currently assistant professor at the Mayo, and so I have him present for half an hour or so, open it up for questions. I'm going to ask everybody to just to foster better interactions, to unmute yourself and ask your question and have a dialogue going that way. Not I'll read them, but I think you get better conversations if we actually unmute and have a direct conversation. I also wanted to make one announcement, is that UAB will be having its annual renal symposium this Thursday. I will provide a link for registration. It's a hybrid meeting for those that might be interested in participating in that meeting. So I hope to see some of you there. And with that, Tim, I'm going to turn it over to you and start the presentation. So again, thank you for taking some time with us.
Awesome. Yeah, thank you so much for inviting me. So let me share my screen. All right. Are you seeing the slides? Just
correct.
Good to
yes.
Confirm. Feel like the one time you go ahead without doing that, somebody stops you. So
everything.
So cool. So today I'm actually going to take a little artistic freedom with the presentation, and as Brad was saying, really hoping for discussion by kind of talking about the roadmap of where we're currently at, highlight some of the work that we've done over the years, but really try to think together where are the gaps and what opportunities there really are in terms of what we can do with imaging to care better for our patients affected by polycystic kidney disease. So again, I want to kind of reflect, try to chart out a roadmap together, talk about, the things that we really feel like are working currently with some of the things that we've developed. Also talk about some of the things that maybe aren't working. And here it's not necessarily that they're not working, but maybe just haven't gained as much traction in either the research area or in terms of clinical integration or implementation of the things that we could potentially do in the space of radiology, really to try to answer the question together, what's next in this space. And I put here at the bottom, this is sort of my mantra for a lot of the work that I do. Really, the goal is to increase the amount of information that can be extracted from a single radiological exam. So let's start by walking through a few things from our past, things that we've focused on, really put it in context, and then move forward from there. So I did want to touch on some of the work that we've done in the past in both the space of trying to advance the acquisition protocols. So essentially, how can we acquire better images with more information, and extract things, biomarkers, et cetera, that we didn't have access to before developing those tools. So, we worked a fair amount on things like quantitative MR imaging, here really looking for methods that could maybe go beyond obviously total kidney volume and extract additional information, particularly about the kidneys, things like, could we characterize fibrosis, or could we characterize microscopic cyst burden, something maybe beyond what we can actually resolve with the current images that are acquired. Something we've moved into more recently as well is acquiring 3D ultrasound. So they're trying to essentially have a much easier, maybe cheaper exam where we can still get a lot of the information that we currently desire for the care of our patients, but essentially doing this potentially much more efficiently. On the flip side, we've also worked a fair amount on developing new image processing techniques. So a lot of this work was really trying to ask that question of, okay, how do we extract more information from the routine exams that are already being acquired And this obviously opened up a really nice opportunity for retrospective studies where we could go back to our cohorts like CRISP and HALT, try to pull out additional information and see what the prognostic value of those metrics were. We've also done a lot of work, as I'm highlighting here in the lower corner, of how do we actually integrate these tools into the clinical practice. So obviously it's great to be able to do this in a research setting, but our end goal really is to get this in the hands of our radiologists, our clinicians, and ultimately our patients as well. So this has been a big area of focus for our group, trying to get, once we develop these tools, let's get them into the practice. So I thought it might help to kind of talk through each of these projects, just in terms of sort of the advantages that we see exploring these techniques, as well as some of the challenges, and maybe hinting at reasons why maybe we're not seeing as big of an impact from some of these tools that we've investigated. So the first one was quantitative MR imaging. And, we did a fairly extensive amount of work in preclinical imaging to establish some of these techniques, essentially looking at using quantitative MR imaging to do things, again, like characterize fibrosis or microscopic cyst burden. And then we looked at applying these techniques in patient populations as well. However, I wanted to highlight, a number of the challenges that we see with really integrating these tools in practice as well as in research settings. And some of these really go to the fact that there's a lot of variability in these imaging techniques. So even though a place might say we're doing diffusion weighted imaging or we're doing magnetization transfer, there's a lot of variables obviously that go into how you acquired that image that ultimately drives the signal that you see. So I think some of this lack of standardized protocols has really led to maybe less enthusiasm for what utility they might have in the clinical practice. Something that we definitely ran into early on with this as well was really trying to do anything with prognostic model development, because obviously we hadn't been acquiring images like this. We didn't have any access to retrospective data. So a lot of these tools, I think, are things that we're going to be seeing much more value in the future, as long as we continue to investigate them, continue to acquire data, and really start to understand how they can be used for number one, predicting progression or understanding a bit more about what's actually happening, not only in the kidneys, but also extrarenal manifestations of the disease as well. So I think in terms of clinical integration, there's obviously difficulties with expertise in terms of trying to get these acquisitions into the clinical practice. But there's a lot of really nice work that's happening right now, trying to unify and standardize the imaging and in terms of collaborative research projects to essentially standardize how the images are acquired and be able to then assess their reproducibility and generalizability to different institutions as well. As I mentioned, we've also been investigating 3D ultrasound techniques. So here, obviously, one of the goals is to be able to quantify a lot of the metrics that we already have access to through MR imaging. So doing things now like getting accurate measurements of total kidney volume from the 3D ultrasound scans themselves, as well as investigating, doing things like cyst measurements as well. So, this is obviously a non-invasive technique. Where we've moved a lot of this work to actually is to look at improved monitoring in pediatric patient population. So I think that's where we might see a big impact with this type of technology, being able to hopefully get the same information from a much easier modality to scan the patients with. We will still see challenges, obviously, with variability in the image acquisition, and something we've definitely run into here is incomplete coverage. So it can be difficult, particularly in more advanced or severe disease stages, having incomplete coverage and thereby not being able to accurately measure total kidney volumes. But again, I think there's a really nice opportunity here. We've seen very nice comparisons between the measurements that we can do in 3D ultrasound compared to MR, and that's kind of where a lot of our work has been right now, is really trying to prove the efficacy and the accuracy of these techniques. And then on the flip side, wanted to highlight the work that we've done with trying to advance some of the image processing methods. So this study actually is now a good 7 years old, so I apologize, but I think it's helpful to talk about, things that we saw a lot of promise that maybe are still gaining some traction. But what we saw in our initial studies was really a high predictive power from some of these image features that we could pull out beyond total kidney volume. So really the question here was, is there additional information from the images that could predict subsequent progression beyond total kidney volume? But a lot of the challenges here again are the variability in image acquisition. And also the incompatibility across modalities. So essentially, if you're sitting on a population of patients that have maybe been scanned by CT and MR, it's going to be very difficult to try to use a technique like image texture features to do any kind of predictive modeling or anything along these lines, just because the signal is completely different, obviously, in those different image modalities. So I think the future directions here is a big focus on standardization. So, having standardized imaging protocols that are used when scanning the patients, as well as advanced computational techniques. So we're thinking about, more advanced ways that we could, train models to extract features from the images that might tell us a bit more, not only about current state of disease, but also likely how the patient will progress over time. And that brings us kind of to the last little background section here, but wanted to highlight too, the advancements that we're doing in image processing. So obviously going beyond just segmentation or volume measurements of organs, we've done a lot of work trying to advance the amount of information that we can extract automatically. So for example, now separately tracing every cyst within the kidneys or the liver. And I think this one has really opened up a lot of doors for looking at, number one, the clinical utility of metrics like cyst number or other more advanced metrics that we can pull out from the kidneys, really with the goal of doing improved monitoring. Some other benefits here, obviously, is that this can be applied to routine exams. So that's a really nice opportunity to now explore these new imaging metrics in a lot of these retrospective cohorts that we have. There are some challenges, obviously, with doing this at different institutions. So things like the technical implementation of the algorithms. It's also very difficult actually to review the output of these AI tools. So you can imagine you're just looking at a slice within a 3D volume, and you're trying to determine whether this conglomerate of cysts is actually separate cysts or just an individual one. So we've worked quite a bit on trying to develop tools that help with how you can actually review and evaluate the output of these AI tools as well. And so, as I mentioned, then, this opens the door for doing a lot more investigation into the utility of these metrics. So this was a study that we published last year where we looked at now using that automated AI tool to extract additional imaging biomarkers in the CRISP population. And what I think is really nice when we look at this figure, so for one, if we look at total kidney volume and we compare essentially the images from top to bottom, these are each identified patients with very similar total kidney volumes, but actually very different phenotype, appearance of the kidneys themselves. So I think from the clinical perspective, it's very obvious to look at the kidneys on the top And maybe even though the patient has a large total kidney volume, you can still see there's a lot of healthy renal parenchyma. Actually, kidney volume is really driven by only a few cysts, maybe potentially mostly exophytic cysts. So you would predict, that this patient is going to do much better than the one below. But actually, based on total kidney volume, you would make the same prediction. And when we started looking at some of these other metrics like total cyst number or the cyst parenchyma surface area, which is essentially the area of the cyst that's adjacent to kidney parenchyma, we saw that those metrics just by themselves had much stronger prognostic value over total kidney volume. So a lot of the work now is really how do we incorporate this information into newer prognostic models themselves. Just wanted to highlight, I think a really nice opportunity too then is how, development of these AI tools not only can facilitate asking new, research questions, but there's also questions that can be asked kind of on the AI side of things. So here we had a collaboration where essentially got the other institution that's led by Dr. Kim going with the same tool that we had developed, and they were able to look at different ways of training the model and how it performed on multi-institutional data sets. And so we can even kind of start asking questions from the AI side in terms of, what's the best way to maybe curate your data set to train sort of the model that will generalize best to unseen cases. All right, so I promised this was actually about AI. So let's take a step back because, I think right now AI is definitely heavily hyped up in some sense, and so I want to put it all in context for us. What's really happening. So really, when we talk about artificial intelligence, all we mean is that we're developing a computer system to do some form of simulation of human intelligence. So things like learning, reasoning, problem solving, perception, which is obviously the main focus of myself and my lab, as well as language understanding. And so the core components here, one is machine learning. And essentially what we mean is that we're developing a computer system that learns from the data. A lot of the work that my lab does is actually just a subset of machine learning that's called deep learning. And this just means that we're using very complex model architectures or neural networks, as they're called, to model really complex patterns in data. So the idea behind deep learning is that there's the potential opportunity to learn really complex patterns, probably beyond what a human would be able to extract from the data, and generally just trying to get the models to learn the important features from the data itself, as opposed to sort of hard code what are the important metrics to use in, for example, in a predictive model. So I like to highlight here, this is what I think myself love to think we're doing with the AI stuff, but when we think about clinical applications, right, this is more what we're dealing with, a little toy. So I wanted to highlight, the applications that have really been impacted in the radiology space, and a lot of our successes, I would call essentially low-hanging fruit. So and maybe it's low-hanging because now we've kind of figured out how to solve this problem, but the way that we've really impacted medical imaging so far from the AI perspective is doing things like work list prioritization, doing things like image improvement, so denoising. And obviously all of these have really high value. So something like denoising, now you can acquire a CT image with a much lower dose. So obviously a much lower risk for the patient, but using AI methods, you can recover essentially a much higher dose image, much higher resolution, much less noise, thereby making a much more efficient acquisition. And then obviously object detection, so doing things like identifying suspicious lesions, as well as segmentation, which is sort of the bread and butter of my lab. But what I think is getting, probably seeing much more attention than is some of these moonshot applications, as I'd like to call them right now. And this is something obviously I'm heavily involved with as well. But to be honest, we haven't seen this necessarily integrated into clinical practices. None of the FDA approved AI tools are doing something at this level, which is trying to do things like predicting benign versus malignant tumors, trying to correlate radiology findings to pathology, so doing things like tumor subtypes. But a lot of times what we're doing is we're essentially taking biopsy or pathology information that might have occurred at a later date, looking back in time at the radiology scan and trying to see if there's features or information within that scan that could have predicted that outcome. So for example, can we automatically identify an oncocytoma versus an RCC? And these things on the research side, we're seeing a lot of successes, but trying to clinically implement that is really difficult, and obviously comes with a lot of risk as well. So I did want to highlight, obviously the tool that we developed for total kidney volume. Trying to develop this on the research side now is a much lower lift than trying to figure out how to most efficiently integrate it into the clinical practice. And I was just highlighting here, the research goes back to 2015 in terms of doing this automation. And then we started in 2019, so a number of years later, starting to look at clinical simulations or bringing this into our practice. And so now we do have this sort of fully rolled out in our practice. The algorithm gets automatically triggered when a specific series or image is acquired at our institution. We generate kind of an automated report that then the radiologist can approve, which will go downstream to our nephrologists and ultimately help care for our patients as well. I did just want to highlight some of the other areas that we've worked in the renal space that have impacts, obviously also for our patients affected by polycystic kidney disease, but we've worked on developing tools for example, to do automated quantification of renal stones. So this can be from either single or dual energy exams. We automatically segment the kidneys, we detect the stones, and we provide an output report that then characterizes or quantifies the stone burden. And in the case of the dual energy exams, we can do things like composition analysis, so basically uric versus non-uric acid stones as well. And then, as I mentioned, also trying to go after not just characterization of cysts, but actually predicting malignant tumors as well. So this is another project related to not only segmenting, again, kidney and simple cysts, but also complex tumors as well, and providing metrics related to the tumor in terms of volume, max diameter, and these type of things. So to get back to some of the work that we're moving ahead with, so we obviously developed a tool for MR images related to doing this kind of instance level segmentation of the cysts. And so we've also been working on developing this for CT as well. And so in this case, driving this off of the contrast phase exams. But again, this has led to efforts for curating the data and really evaluating how accurate the models are. Just wanted to touch on some of the other things that we've been considering, and again, really hoping to get some input in terms of where folks think the best directions we should be headed moving forward are. But obviously, we can go after other things like not just segmenting the cysts, but also classification. So, for example, we could use parametric information from the T1 and the T2 images to do things like separately identify hemorrhagic or proteinaceous cysts automatically as well. And another opportunity is with cyst tracking. So something important maybe to note about the model that we've currently developed is there's not really an automated way to then automatically track each individual cyst. We can do that, visually, et cetera, but we're also working on ways that we can do this automatically. So essentially, if we have two different time points, let's automatically map the cysts between the two time points, and then we can characterize changes at the individual cyst level as well. So, I think where we're going, right, is to try to just continue to develop the imaging biomarkers, basically the wealth of information that we're providing from a single exam. And so, I think soon, not only are we going to be generating information about total kidney volumes, but, even from a single T2 weighted MR exam, just highlighting really the wealth of information that we can get in terms of imaging metrics, thinking about texture, as well as circling back to some of these ideas we had with the quantitative MR as well. So I think, what I kind of was hoping to talk through together really is what do we feel like is the missing part of the story, right? Is it the story besides the cysts? Is it the story inside the cysts? Is it the story outside the kidney? So is it, more important that we start really investigating the extra renal manifestations, or is it potentially the story outside the body as well? There's obviously a lot of people to acknowledge throughout this work. I just wanted to highlight really the folks that had mentored me through my journey in PKD. I essentially started in 2013 with funding from the Mayo PKD Center, and I would say it's just such an amazing community. I'm so happy to be a part of it. And Adriana Gregory's done a lot of work within my lab with a lot of the recent developments that we've done. So with that, I'd open it up to questions.
Thank you very much. It's open for questions. If you have questions, please raise your hand, unmute yourself, and participate in active discussion. Yeah, I'm going to start out with a question, if you don't mind. Showed a lot of promise in what AI can do. Is there anything you found that it just can't handle? I mean, what is the biggest challenge in the AI field when it comes to image analysis?
Yeah, I think that's a great question. To be honest, I think some of these moonshot type of applications are a lot bigger of a challenge than we give them credit for. So, for example, trying to predict something like a tumor subtype from the radiology image. This is a really heavy active research area, a lot of publications showing we can do this with 95% accuracy, et cetera, et cetera. But as soon as you kind of dig into the study, the data, you find out, well, so I'll just take actually that exact example about predicting tumor subtypes. Oftentimes in a publication, you'll see, well, they included something like a simple cyst within their data set. And from my perspective, that's almost a give me, like you can easily identify something like a simple cyst from something more complex, but they're using that to almost heighten some of the performance. And so I think what my concern is that there's just such an issue with trying to generalize these models to unseen data. So you create a model at Mayo Clinic, and then I want to apply it at UC Denver or where, right? Then there's the images are acquired completely differently. And so to think that you're going to have a model that can just generalize in that sense I think we're a little ways away from doing that. Humans are really good at, for example, I could show you how to trace organs in an MR scan and then just give you a CT exam and you could nail it out of the park, right? AI models are challenged with that kind of task because it's never seen a CT image. It's never seen a kidney with a 100 a Hounsfield unit versus the signal in the MR, right? So I think I don't think it's impossible, but I think we're farther away from that type of solution by AI. I think we're still at the stage that you'll always need to evaluate it in a new system and see what the level of performance is actually on your data. Not to get too long-winded, but I think that's a great question, and that's kind of how I feel the current state is right now. So that's why I lean more towards things that are very explainable. So that's why, right, if my model traced cysts, a human could review that and make sure it's correct. If it makes some prediction that's beyond what the human might agree with, like saying, this is a Bosniak 4, and the humans can't, there's something about it they can't figure out. And I don't know. I think that's the challenge. So maybe I'll stop there.
So the radiologists are safe for right now, right? Is that what you're saying?
They're definitely safe. Yeah. I mean, one of the head AI guys, I can't remember how long ago it is now, but yeah, he said they were going to be replaced in 5 years. That was quite a while ago. So yeah, we definitely need a human in the loop.
Jim.
Yeah, my question was actually closely related to what you were just talking about. How far away are we from entering this sort of thing, this sort of analysis in the clinic? And how are the radiologists taking this? Are they being enthusiastic about this as an additive effect, or something that can help make decisions on things that they have trouble making decisions on? What do you think?
Yeah, to be honest, I think it's a little bit mixed. That's been my experience. So we definitely have people that are very, very enthusiastic about what these tools can do and how they can further improve, reading and exam. But I can speak towards, we've implemented a number of commercial AI tools, and I won't comment on which ones, but we've definitely seen a lot of frustration where the radiologist might be reviewing too many false positives, right? So a lot of times they'll tune their model to be really sensitive because they don't want to miss anything. But now they're drawing attention for the radiologist to all these kind of false positives that then they have to kind of question themselves as well. So I would say with a lot of the things like providing metrics, like something like kidney volume that would take a radiologist 2 hours to do themselves, they love it, right? Like sign me up yesterday. But when it leads to more work for them and also can bring into question, potential bias, then it becomes a little more concerning. Yeah.
There's a question in the chat, Dr. Bakhtar. Do you want to ask your question? Do you want to unmute yourself? I can go ahead and ask it. What he says is he found that through MRIs there's moving cysts of patients at different time points. So you were talking about tracking of cysts. So can we expect these tracking also? Can you cysts that change position?
I would hope that we can potentially go there, but that's going to be a big challenge. And actually, I might reference kidney stones as being an even bigger, similar thing where it does become very challenging to say, is this a new stone? Is this a stone that's moved? Cysts obviously are the same question. So I think, again, it's what we're trying to do is automate it so that you would like have the same color or label for this cyst from 2 time points. But I think you'd still have to review that, yes, that actually tracked the correct cyst. Because as we know in PKD, right, the new cysts are forming, cysts are rupturing, et cetera. So I don't think it'd ever be like a necessarily solved problem. There would still be that human element of needing to understand, yes, I think that's potentially a cyst that's gone away or a new one that's formed. And I see that also with trying to do, tracking of stones, for instance, is going to be a really big challenge, but would be really nice if there was some level of automation to that.
Okay. Other questions? I don't know who's Sarit? Sarit?
Yes, hi. A little bit semi-technical, semi-medical question. I think that dealing with the number of cysts and the way they located with respect to healthy tissue with parenchyma, which is healthy, is, in my mind, more important than the volume. I'm talking both as a patient and as a signal processing, image processing kind of a person. So I take both hats. And I can tell you that the volume is nice, but it's saying very little. So in your AI or in your machine learning, again, calling it AI is a bit misleading, in the machine learning, what you're doing with respect to actual texture in the sense of how much good parenchyma, because I would say that even tracking one cyst necessarily, whether it rupture or not, is less important than saying at each given time, how many of those cysts existing and what is the relationship to healthy tissue. So what are you doing that with the AI, with the machine learning? And is it mainly, because we're talking about type of tissue, is it mainly supervised or actually not supervised, allowing the machine learning to come with those kind of points which could be used? That's one part. And the second part related to the fact that you are trying to run the model on images from different institutions, acquire differently while you trained it on in a different institution. So are you trying to use the machine learning actually to solve this particular problem? In other words, it's a different aspect. You're not even looking at the medical side, but have a total different path where your machine learning is actually trying to, you train it on different institutions or different acquired images, and then you try to let it find out how it can register those. So 2 questions.
So, yeah, I feel like there was a few questions. So one was the kind of unsupervised, supervised question. I would say most of what I showed today, models were trained in a supervised fashion. So we would typically have a human reader trace some number of cases. So they would trace things like kidney, liver, as well as all of the individual cysts. And then we would train a model to learn how to basically take in a new MR image and predict or trace the cysts individually. So I think most of our work actually points at exactly your point, that we're interested in providing those metrics at individual time points, right? So a patient comes in and we don't just give kidney volume.
Your email, I'll reply.
Can you mute yourself, please?
Go
ahead.
Some of the, I haven't replied yet. I have a
Dr. Zogby?
just after I'm done this week, I will reply. Okay, it's about the epic, some of the epic issue.
Nicole, can you mute him?
Is there a way to mute?
Thank you.
So you're saying basically that, do you see a way where you can use the unsupervised machine learning to actually come with more what I would call texture related points? Because I think it's so crucial, like I said, more than volume or even tracking necessarily a cyst, but more looking into and helping us to actually identify changes or specific points in the tissue where it's so important.
Yep. Yeah. And so, that was kind of the first study we had done was, a radiomic based study. So there we were extracting texture features. But I think to your point, there's a couple ways we could approach, but largely doing it through a deep learning or potentially an unsupervised way to rather ask the model to tell us what are the important features, right?
That's what I was,
Yep, that's spot on. So I think that's an active area that we want to look at right now. A lot of what I showed really has that kind of explainability piece to it. So you can literally look and say, okay, this is the size of the kidneys. This is the number of cysts, this is size distribution, et cetera. And we're seeing so much power from those metrics as predictive for subsequent progression. But I think you're spot on that there's way more to do. For sure.
Yeah, no, I agree with the number of cysts, because if you look at it, that's important. And if you look also at the liver, it's very different than someone had one gigantic cyst, which, you could treat today with the drainage and the special foam treatment. It will work much better when you have many small cysts, which is almost not possible to treat. So a lot of things can come out from that, which can help at least with slow down disease. As far as the second question, just to clarify, is actually using your machine learning to work on the data coming from different institutions to help you to actually register that data. In other words, train it on different sources of data, but let it sometimes even with not supervised or at the beginning supervised to actually help you just to help it to later register those different sources.
Yep. Oh yeah, no, I think that's a great point. We definitely have done a lot of work with that, trying to look at multi-institutional data. How do you best adapt, models to new institutions, for instance? You're even hinting, there's some ways to try to harmonize data through deep learning types of approaches.
Exactly,
So,
yeah. Mm-hmm.
Yep. No, I think those are great points.
All right, Vinmath, you want to ask your question?
Hi, Dr. Kline. I'm Vinu Rao. I'm a PhD student, MD PhD student at the University of Kansas. And something I was really curious about, I was really interested that Mayo has automated triggering of the algorithm to calculate TKV once the series is ordered, like the imaging series is ordered. I was wondering about some of the challenges and successes that you've had with incorporating it into the EMR. Is it incorporated into the EMR, or is it on a separate platform altogether when the algorithm is triggered and giving those values for both the radiologists and the clinicians?
Yeah, those are great questions. I can tell you that integration is a huge challenge. It is currently ultimately landing in the report, but I can give you probably a quick it kind of sounds like you're interested in a little bit of the technical aspects, but largely we have a specific series description from the MR scan, right? So we basically, when we're acquiring this T2 weighted coronal exam, it has a specific series description, and that's what we use to route to, I'm oversimplifying it, but that's what we use to route to the AI algorithm itself. So we basically have that as kind of a packaged algorithm that all it does, it sits there and looks for a DICOM series, reads that in, does all the processing, and spits out things like a DICOM seg, a structured report, etc. And then that lands actually in our PACS system for the radiologist to review. And we actually built a viewer specific from the PACS system where they can like scroll through the image series, make sure that it correctly identified everything, click a button to accept it, and then we automatically template like a report for them. So it has all of the metrics that they can basically put into the report if desired. But that's like a big challenge, is how do we most efficiently get it into the practice with limited impact? Because as soon as you have a radiologist clicking 5 buttons, you've lost the game and you don't have an algorithm anymore, right? So yeah, but I mean, if you have more questions about that, feel free to reach out.
Dr. Watnick.
Thank you.
Tim, that was great, inspiring. I was wondering if any of those, especially the more automated things, are available to other investigators for use in clinical trials.
Yeah, so it's
I don't know if you
kind
guys
of
have licensed it or how it works, like, because I think it would really save a lot of cost, actually.
Yeah, and we've done it a few different ways. So we have licensed the algorithm to support clinical trials, so that, if we're like help with a centralized reading for a study, then we'll license things. If we're working with a research group, we'll either try to help them implement things on their end, or we've done things like kind of packaged it up, and then it's like sits sort of as a virtual machine that they can just run cases through. So for example, that's what we did with like Dr. Gansevoort's group. So they essentially have this little utility sitting on a workstation where they can just send images, get, the volumetrics run and the output. So might be worth discussing a little more your exact use case, and then we can figure out what the easiest way forward. But I mean, that's, a big part of what we're trying to do is facilitate getting more people using the tools, and then it just opens up so much opportunity to figure out the utility and think about what else we should be developing, right? So
Thank you.
Dr. Koda?
yeah, thank you.
Great work, Dr. Klein. My question is somewhat related to the previous question by Terry, as to if someone were to develop an new algorithm from the scratch, what would be the minimum number of images that would be required for the discovery cohort and the validation cohort, given that you have seen the heterogeneity in different imaging platforms?
Yeah, I mean, so it really depends on the problem you're trying to solve. But I think probably the biggest piece of advice I would say is to stratify your data as well as you can. So you want to consider what's the range of image acquisitions that I want to be able to use my tool on. So that can be everything from the slice thickness, the resolution, the scan manufacturer, the modality, but also then you want to encompass the full extent of disease burden that you're anticipating. So I can speak from experience that like the original model we developed was mainly developed on very severe cases, right? Like those were the patients that were getting scans. That's what we had access to. And what we quickly realized was actually for healthier or milder cases, that's where we could see some struggle because the algorithm was really looking for bright cysts on a T2 image, not kind of a normal appearing kidney. So I think the direction I would always say is try to get as wide of a distribution for any of those variables like phenotype, image type, and that can really help alleviate the sheer numbers of cases that you need. And again, something else you can do that we often do is we start out with a small data set. Our goalposts, right, how good we want the algorithm to perform is based on looking at how well two different people compare. So that's our goalpost for how good the AI needs to be. It should perform at the level of human rater variability. So you could, for example, then get a small cohort, train an initial model, evaluate it, and see how far away you are from the performance you need. And that can help you guide how many more images you might need to acquire. And that's kind of how we structure our machine learning projects now. I hope that helps.
Yeah, awesome. Thank you.
Yeah,
That's good. You're muted.
Me or?
Yep, you.
Okay. It's a bit of a tangent because we're talking PKD, but nonetheless, since we are trying to have the algorithms or the machine learning working on structure and things such as fibrosis, are you or any of the other groups working to try to have it used for rejection detection?
Rejection, I'm not
transplant
too
rejection.
involved. I know there's definitely work going on in that space, but I haven't worked on that at all. No.
Okay, it's just that the fibrosis and such could help. Right now, it's mainly invasive, with the biopsy. So.
Yep.
Thank you. Nore?
Hi, Nuria Pastor Soler from the Keck School of Medicine of USC in Los Angeles. Thank you for the wonderful talk and the beautiful images and for all the considerations. So I'm interested in metabolic health, and a lot of us are when we treat patients with PKD. Metabolic health, we can use really waist circumference. Some of our patients want to be on statins right away, even though, some of the younger patients, even though we don't know that the statins are going to work in a particular patient. So I was wondering, what are your thoughts about evaluating visceral abdominal fat in these patients as a way to track metabolic health, especially with the availability of the GLP-1 agonists, where you know, the body mass index in some of our patients may not be as accurate, and but it's very important for their cardiovascular health. And thank you for everything you do for the community and the availability of the tools.
Yeah, no, thank you. Thank you so much for that question. Actually, unfortunately, I cut 2 slides directly related to that. So we've done a fair amount of work with exactly what you're saying, kind of body composition type of analysis. So maybe you're aware of Dr. Kristen Nowak at UC Denver. We do collaborate with them pretty heavily. I had actually been invited to a talk at their group a number of years ago and just had one slide related to something we had developed for doing body composition analysis, and that led to a good collaboration. So I could send the paper, but we recently published characterizing visceral fat in the Tempo 3-4 study. And like you said, I think there's a lot of value in these additional metrics related to how they relate to disease burden. So I think that's great. You know, the initial model that we had developed was for CT imaging, and then what we had done for the Tempo was then to kind of extend that to coronal MR images. So in the paper, I believe it's in the supplement, you can kind of see the method that was developed for doing that. But yeah, we really wanted to be able to analyze that also in kind of the retrospective cohorts that we had access to. So I think that's a great point.
All right. Any other final questions? We're right at time. All right, Dr. Kline, I want to thank you again. Also thank the participants for a very active discussion. I think unmuting yourself.
This was great.
It's great. Yeah. Keep up the good work, and I hope that you will reach out to us if there's anything we can do through the PKD RRC to help advance your research program. So
awesome.
Thank
you so
very
much
again. Appreciate it.
All right, thanks all.